Even when access-related factors such as patients' insurance status and income are controlled, racial and ethnic minorities tend to receive a lower quality of health care service than non-minorities. These disparities in quality of health care, combined with other factors, result in highly disparate rates of disease and death in racial and ethnic minorities. For example, in Maryland, black males are approximately 12% of the population, but account for 41.4% of deaths due to cardiovascular disease before the age of 65 in Maryland. White males, while approximately 31% of Maryland's population, account for only 20% of these deaths. Minorities in Maryland also suffer disproportionately higher rates of cancer, asthma, and diabetes. Maryland has responded to many of these issues surrounding minority health disparities in several ways. In 2002, the Maryland General Assembly passed Senate Bill 451, which authorized the Maryland Healthcare Foundation to provide grants to programs that reduce health disparities for Marylanders. In 2003, the Maryland General Assembly passed House Bill 883, which required the Maryland Department of Health and Mental Hygiene to develop and implement a plan to reduce health care disparities based on race, gender, ethnicity, and poverty. In 2004, the Maryland General Assembly passed Senate Bill 177 and House Bill 86, which created the Office of Minority Health and Health Disparities within the Department of Health and Mental Hygiene. Also last year, this committee, the House Health and Government Operations Committee, created the Minority Health Disparities Subcommittee, chaired by Delegate Shirley Nathan-Pulliam, to increase the dialogue about legislative strategies to reduce minority health disparities. This subcommittee is the first of its kind in our country. Today's briefing in the House Health and Government Operations Committee will examine in even more depth the problem of minority health disparities in Maryland and strategies to assure quality health care and health outcomes for all of Maryland's citizens. At this point, I'd like to hand the microphone over to one of our committee's newest subcommittee chairpersons, Delegate Shirley Nathan-Pulliam.
Thank you, Mr. Vice Chair. I would like to welcome all of you here today, and as I said, as the Vice Chair just stated, that this is our very first briefing to address these issues, and I want to make one thing quite clear, that this briefing is really about education. This is not, we're not lobbying on any legislation or anything. It's just to educate not only the committee, but also many of you that are sitting in the audience about the importance of health disparities and what we need to do to correct these deficiencies. And so we will, there are many people that when I look out, maybe after we have had some dialogue and the first speakers, I will then ask a couple of you to stand, because they're from the Urban League to all the different organizations are here, Baltimore Times. There are many, many people that have an interest in what's happening. And since the number one killer that I'd like to share among African Americans and other minorities are, and all of us really, is cardiovascular disease. We just happen to have the highest percentage. And cancer is the second. So we will first start this morning, this afternoon I should say, with Dr. Friedman, Dr. Harold Friedman, he's the director of the Center to Reduce Cancer Health Disparities, the National Institute of Health. And we would like, Dr. Friedman has a very extensive bio. I don't think I have time to go through this whole bio, but I'm sure he comes well prepared to share the kind of information that we need. After Dr. Friedman, then I will introduce Dr. Myron Weisfeldt, who is the chair of the Department of Medicine at Johns Hopkins University, and he will address sickle cell anemia and adult sickle cell anemia specifically, and any other diversity issues that he's addressing at Johns Hopkins. Dr. Friedman.
Mr. Vice Chairman Hammond and Delegate Shirley and Nathan-Pulliam, I am very honored to have the opportunity to speak to you and the other delegates who are present here today about a very critical American issue. The issue of the point that some American people who become sick and have cancer in particular, which is my interest, do not do as well as others. And that's how we define disparities. The question becomes, how do we apply to all American people what we know that all American people should have? The first challenge is to identify the populations that are not doing as well. In America, we have done this essentially by two ways. The most extensive data we have since the early 1970s is on disparities according to race. And that first set of studies came out of Howard University by Dr. Henschke, who looked at data that would have been available to anyone, but published an article in 1973 that showed that in the previous 25 years, prior to 1973, there had been an alarming increase in cancer death among Black Americans in America. We had known something about that up until then, but his paper focused on the problem, even to the extent that the national database, which is called the SEER database, began to look more intensely at populations groups according to race and ethnicity. So early 70s is really focused beginning on the problem that we're going to discuss from Henschke's work. At the same time, in 1971, President Richard Nixon had declared a war against cancer. And in that war, he felt at the time that America could win this war in approximately 8 years. He likened it to putting a man on the moon. Well, as it turns out, it looks like it may be more complex to win a war against cancer, which turns out to be not one disease, but more than 100 diseases, more complex than it was to put a man on the moon, which was done by Kennedy. And so as we move forward, we have a situation where race becomes an issue, and we'll discuss that a little more, but there's another issue that plays in Delegate Pulliam and Vice Chairman very strongly, and that is poverty. Today we're going to discuss the interrelationships between race and poverty, and we're going to bring in another element that I believe is important here, and we'll say social injustice. So I'll spend most of my time, which is limited here, to paint the very, very big picture of what drives disparities, and I'll be talking about three things that overlap. I'll be talking about the effect of poverty itself. I'll be talking about culture and behavioral issues, which vary in populations but are not related to what race you're in necessarily. And I'll be talking about social injustice, including what has happened according to our nation's history. So, moving the argument forward, first of all, the question could be, well, what are disparities? And the Health and Human Services Department defines disparities as defined by populations who have a higher incidence of a disease, a higher mortality, and a lower survival. So we'll function on disparities as related to outcome as the main determinant, and I wouldn't argue that against the point that you could define disparities in a different way, but that is what we're going to use as our definition. And then when you look at it from that perspective, we find looking first at life expectancy, and I'll paint the picture that I don't think there's anything stronger than how to measure disparities by who dies too soon. We find that in America, looking at race and sex, that American white women live approximately 80 years from the time of birth. American white men and American black women have about the same life expectancy, about 75 years, but African American men have the lowest life expectancy, about 68 years. So painting the big picture, it looks like we looked at it according to race and looking at black and white race specifically, that black people don't do as well with respect to longevity, and black men have the worst overall results. And I think that's a very important point for us to keep in mind. Looking at the cancer incidence rates, according to race, we find that black Americans in general have the highest overall incidence. But looking at it from the point of view of sex, it is black men that overwhelmingly have the highest incidence of cancer compared to all other race and ethnic groups. It happens that white women in the nation as a whole have a slightly higher incidence of cancer than do black women in other ethnic groups, which is a point particularly illustrated by the point, a particular disease, breast cancer. White women have a higher incidence of breast cancer compared to black women by a small amount, but black women have a higher death rate. And so we want to separate those 2 points. Incidence high in white women, mortality higher in black women. When we look at geographic areas in America, and there's been a recent study that was published just last year by the National Cancer Institute, which was a very extraordinary analysis. The country has now been divided into counties, thousands of counties. We now understand for the first time what is happening per county in all of America, and there are maps to show this. And when you look at the county level and divide the counties into those that are affluent and those, on the other hand, that are poor by the standard that they use, in overall case, looking at the whole population, the affluent communities have the highest survival and the lowest death rate. And the poorest communities in the nation as a whole, at the county level, have the highest mortality and the lowest survival. When you look at the same issues according to every ethnic group, it varies. But within every group, the same pattern occurs. And there's something that is very interesting here, and that is that Hispanic Americans in the nation as a whole do rather well compared to other American people with respect to incidence and mortality. But when you look at Hispanic Americans as one group, it still breaks down into those who are affluent do better than those who are poor. So those are very important points, and I think that I'm leading to the point that if there are solutions to this problem, we have to take into account what is driving the issue. When you look at the issue of culture, and let's go to that next, how we behave has a lot to do, is a very strong indicator of what outcome will be. For example, the #1 cause of cancer death in America is tobacco. And the #1 cause of death in America that we can control is tobacco. So if there any public health effort that we would undertake, we'd have to take into account the point that if we eliminated tobacco, we would eliminate 1/3 of cancer deaths. And tobacco is the overall cause of, first cause of death in America as a whole. So that would be a first attack, to eliminate tobacco smoking. I know we're doing a lot in this nation to do that. Another behavioral issue has to do with diet. And there's been a lot of recent work on diet. We had a report last year that was revealing, and it showed, for example, that 20% of cancers are related to obesity. And obesity is a thing that happens universally within our population. And as a country, we're getting fatter and fatter over the years. And that's been measured by the Centers for Disease Control. And it's probably related to the way our habits about eating, going to fast food as opposed to fruits and vegetables. Just recently, the Secretary of Health and Human Services came out with a national program indicating the dietary advice for America. And yeah, I'm sure that you've read that. We need to eat about 9 helpings of vegetables a day. I don't know how many people do that, but that's an important issue. So causes of cancer, tobacco, and diet become very important. And to the extent that there are groups of people in America who smoke at a higher rate than others, then those groups of people will die at a higher rate. It happens that the number one group of people who smoke cigarettes in America at the highest level are black males, so we have a challenge in that respect. Culture also involves what we believe and what our values are. Let me give you an example. In a study last year by Mark Otis, a thoracic surgeon, who began to notice that many of his patients were refusing surgery for lung cancer. He did a survey, and he published a survey in 3 different cities. And he found that 60% of African American people believe that if air touches cancer, the cancer will spread. 30% of white Americans in the survey also believed that, so it wasn't that it was all a black problem. Well, what does this mean? If you refuse to have surgery because you believe that when surgery is done, the air will touch the cancer will spread, then this has an effect on the outcome. And so we need to be concerned. I use that as an example of the importance of public education. In Harlem, where I work, I saw this as early as the 1970s, when people would not come in for treatment of cancer. When I looked at the community, some of the people told me anecdotally that they had seen their relatives and friends come into the hospital as emergencies and die 6 months later from cancer. Well, what actually had happened, ladies and gentlemen, to these people in general, was when they came in with an emergency like a colon cancer obstructing, were operated on, certainly the abdomen was open and the air did touch the cancer, but it was probably an open and closed, and the patient died 6 months later from the cancer. But if the community perceives that the opening of the abdomen and the air touching the cancer caused it, then that is a real problem. So I believe this issue of education related to behavior and culture becomes very, very critical. Now, poverty itself is something we need to be concerned about. Poverty is universal. Poverty doesn't care who you are. If you are poor, it doesn't care what race you're in or what ethnic group. It will treat you as though you're poor. That's what poverty does. So poverty is a universal point. But when you look at the various groups of people ethnically, you find that 25% of African American people in this country are poor by the standard of poverty, which is currently $18,000 a year for a family poor, whereas 8% of white Americans are poor. But the 8% are having as great a difficult a problem as the 25%. You have to look at the total picture, but also know that disproportionate poverty reflects itself and causing results in some groups of people to be more severe. Looking at the issue of poverty as well, poverty, if we're looking at it from a health perspective, we see that people who are poor come in later, as I've said in my example, and tend to come in for treatment of symptoms as opposed to coming in before symptoms occur. As you know, there are screening guidelines for at least 4 of the cancers, but if people come in through the emergency room with cancer, they're going to come in late. So poverty is a factor that drives late diagnosis of cancer, but poverty, I want to point out, occurs in a broader context, because if you're poor, you not only come in late with respect to health concerns, you also live in conditions of poverty, poor housing conditions, less social support, lower educational level, tendency toward a risk-promoting lifestyle. And so when we look at poverty, we shouldn't look at it only as a medical concern. If you look at you can't separate poor housing, for example, from poor access to health care. And so when the legislature is dealing with the issue of disparities, it should not focus only on the health part of it, because the health part of it is occurring in the context of a much larger set of circumstances. The relationship between poverty and culture is very key. If poverty is important and culture is important, how do they relate? My own view is this, that poverty acts through the prism of culture and causing its negative effects. And if that is true, then culture has the opportunity to modify poverty's expected negative effects. An example, the Seventh-day Adventists, a group of people whose culture is driven by their religion, do not smoke cigarettes, so they don't develop lung cancer. They're vegetarian, they get that protection that I spoke of before by diet, and they don't drink alcohol. Driven by religion, but yet it's a culture that we can learn something about, and I've visited with these people. And so, I'm not asking that people become Seventh-day Adventists, but I'm saying, let's look at what the results are. The Seventh-day Adventists have the lowest cancer rate in America and the lowest cancer death rate. So there's something that we have to take into account. Poverty, culture. The culture of people where I work in Harlem and in Harlan, Kentucky, where I visited, black and white people respectively, drink heavily alcohol, eat the wrong food, high-fat diet, and smoke cigarettes highly. This culture will drive disparities to a higher level. So this understanding between poverty and culture becomes very critical. Another element that I'd like to raise for your consideration is that in America, we've made great progress since the war on cancer was declared by Richard Nixon in 1971, but there's a huge disconnect between what we have discovered in this great research community that we have at the NCI, and elsewhere. There's a disconnect between what we've discovered and what we deliver to all American people. And this in and of itself is a driving force for disparities. We don't need to discover a single thing more to correct most disparities, except to discover how to apply what we know. And that's a very important point, that we need to connect what we discover to what we deliver. I'd like to talk about the areas of excess mortality. In my own experience, a colleague and I published a paper that became world famous in 1990 in the New England Journal of Medicine. It's called Excess Mortality in Harlem. And what we found and showed in the paper that was published in a respected journal, that a black male in Harlem has less of a chance of reaching age 65 than a male in Bangladesh, known to be a third world country. And so we have third world communities in the first world. And Harlem is just an example of such a community. You have those communities here in Maryland. And I was looking at Claudia Beckay's statistics. And I found, looking at these statistics, that in Maryland, Baltimore City and Queen Anne's County, for example, looking at real data from the state of Maryland, have excess mortality. And so it raises, you know, we had a tsunami that occurred recently, and we're all very concerned. We're all very concerned about the tragedy that it killed perhaps 150,000 people. But what we don't take into account, I don't believe, ladies and gentlemen, is that there are silent chronic tsunamis occurring in our communities as we speak here today. No drama, no flood, people dying quietly in the Harlems of America. I believe that we should treat the chronic disaster areas, such as the Harlems and the Baltimore cities, as though they were natural disaster areas too. Although it's quietly happening, many more people are dying in chronic, quiet areas of excess mortality than in the tsunami. And so I take that as one of the recommendations I'd like you to look at, if you have not already, and that is, we have concern about the universal issues. 45 million uninsured American people, unacceptable in this country. And we have concern on another level, what is happening in our local communities, so that without fixing the big problem, such as universal access to health care, everybody has health insurance, a big fix, we need to do that. We can do some smaller fixes. We can go to the areas of excess mortality and create programs that will try to raise the level of survival from various diseases and using techniques we already know about to the level of the main society. And so I believe this is a strategy that's to be taken into account. I know my time may be a little short, Delegate Pulliam. I'd like to mention a particular strategy that we've had some success with in the community where I work, looking at Harlem and going back to some 20 years ago when I began to do special programs. We did two things that were very, very successful, and say three things. First of all, in Harlem, that has the highest mortality in New York City from cancer, we created screening programs that were free or low cost, and using breast cancer as an example. We did that by 1980. It did have an effect. The women came in to get tested. But we soon found out that it wasn't enough to simply offer the test. The mammogram, after all, doesn't cure breast cancer. The treatment does. So we had to take a second step. We created a program starting in 1990. It was based on the point that we'd had hearings around America on cancer in the poor, and the poor people in America of all races and ethnic groups told us one thing in particular. They told us they had difficulty in negotiating the healthcare system. They couldn't get through the system, even with a diagnosis of cancer. We created a patient navigation program, which picked up at the point of the positive findings you might have on a mammogram and assured that everyone who had a positive mammogram, suspicious microcalcification is a typical finding on mammography, that everyone with a finding rapidly was treated at least by the standard care. When we did these two things, the screening and the assurance that people would get treated rapidly, at least by standard care we call navigation, the results dramatically improved. We went from a 39% 5-year survival in Harlem now to a 70% 5-year survival in Harlem. Still not as good as American white women, but much better than before. The point that I'm making here is that there are two levels of concern. You could pass laws that affected everyone in Maryland or in the country, such as assuring access to care for everybody, very important, number one. But you could also do special things in the communities where the enemy is invading the most. In a real war, which we have fought in this country from time to time, you wouldn't think of developing destructive weapons against the enemy and not firing them against where the enemy is. In the war against cancer, we developed the great guns and didn't apply them where the enemy was invading the most, such as in the areas of excess mortality. I suggest that we need to relook at that and change that philosophy and apply what we know with respect to culturally targeted education sensitive to the community we're trying to help, along with creating access to health care, screening, diagnosis, and treatment. I was told before I stepped up here that you have a new law in Maryland. I'm not sure for sure that it's true, that when people have cancer in Maryland, they will get treated. If that's a fact, if it's not a fact, it should be a fact. People who have cancer will get treated. There's no question about it. People who have cancer will get treated, and it will be at a cost. What we have to decide politically and socially in this country is, will we treat them when they develop the lethal disease as soon as we can, or will we treat them later at a higher price and then they'll die? And so I believe that there's some critical suggestions that I would make here, and I'm going to try to end my talk here. I don't want to take up too much time. But I want to make several suggestions, and I'll go to my text in order to make my final suggestion. First of all, I suggest that there be immediate medical coverage provided for the uninsured and underinsured at the point of the finding that is suspicious for cancer. At that point, it's got to be paid for anyway. Make it a law. Number two, I suggest that geographic areas of excess mortality should be delineated, and I think you've done that, and targeted with intense approach to providing culturally relevant education and appropriate access to treatment. Number three, I suggest that these communities that have the highest death rates should have within them developed what we call patient navigator programs, using community people to be the navigators. And that's another thing too. People get employed who are in the community, They have the sensitivity to communicate with their own people. Let the people in their own communities help to navigate the people through this system, through this very, very tough system. We need to also, another suggestion, monitor treatment equity according to standards of care. Because as you pointed out, Mr. Vice Chairman, in your opening remarks, studies from the Institute of Medicine have now shown that even at the same economic status and same insurance level, Black Americans do not get treated the same as white Americans for very complex reasons. We need to monitor health care to make sure that there's equity for everybody. And it works for Black Americans, it'll work for all of us. Another important point, every individual, regardless of economic status, should share in the responsibility for promoting his or her own health. That's a very important issue. We need to help people, but people need to help themselves. You know, you don't have to smoke cigarettes unless you get addicted to it. It costs money to smoke cigarettes. People should not smoke no matter what their economic status. Summing it up, I think that we're looking at a very, very complex series of events that are causing disparities, that are an overlap between economic status being low, poverty, number two, behavioral factors that overlap that, and thirdly, the nation's history of social injustice, which has driven people into poverty according to certain groups. We just celebrated the birthday of Martin Luther King. And Martin Luther King said something very important and pertinent to this discussion today, before he was assassinated in 1968. And he said, and I quote, "Of all of the forms of inequality, injustice in health," he said, "is the most shocking and inhumane." That great leader also said, "The arc of the universe is long, but it bends towards justice." Thank you very much for inviting me here today.
Thank you very much, Dr. Friedman. You shared a lot of information, and I'm sure you'll be able to give us some of your additional data that you have. And I'm sorry that the audio-visual equipment wasn't compatible with yours, so you could have shown us from that perspective.
I passed out this to all of you.
Thank you very much. At this time, we could entertain some questions before you go to the Senate. Delegate Frank first.
Thank you, Madam Chair. Thank you for your comments, Dr. Freeman. You mentioned smoking as a major health problem. Do you have any data about African-American teenagers smoking versus white teenagers smoking? Is there a disparity in that demographic?
Yes. The recent data is showing, which is a change, that African-American teenagers are smoking less than white American teenagers at this point. That was not previously the case, but that is currently the case. The important point here, Delegate, is that it appears that 90% of people who smoke begin smoking when they're teenagers. So it looks to me like if you're going to spend the money to correct this problem, it ought to be directed toward the youth to prevent cigarette smoking. But it does appear that African American people have somehow gotten the message, young people do not smoke as much as white teenagers, as previously they did.
That's what I thought.
Yes.
But thank you.
Delegate Costa.
Thank you, Madam Chair. Welcome, Dr. Freeman, and I appreciate you coming here, and I hope that this isn't the last time we see you. I think you can be a valuable resource for us in this whole process. On your chart number 9, the one that specifically says life expectancy at birth, is the disparity in the age between the white female and the black male, is that based on cancer, or is that just overall health disparities?
This chart is about overall lifespan, and it's not related to a particular disease. It's showing that white women have the best results and black men have the worst results. Time of life expectancy from birth. If, I want to clarify, if you get to an older age, so you get to be 65 as a black man, your chance of getting to a greater age is certain, or nearly certain. This is from life expectancy and it involves all causes.
Everything.
Yes.
Okay. And one other question. In next slide, your slide number 24, where you have causes of health disparities, You've got poverty, low economic status, culture, and social injustice. I understand most of those terms, but in your opinion, explain to me, as a representative from a rural part of Kent, what exactly is social injustice, in your opinion?
Well, you know, when we thought about this, in America, we've dealt with racial injustice, and it is still, I think, the most important historical element of social injustice we've had since 1492. Columbus was discovered in America, I like to say, and we've had a history of colonialism and racism for 500 years. So race is the most egregious social injustice, but it's not the only one. We have social injustice according to sex, according to age, according to sexual persuasion. There are many forms of social injustice, and when we came up with this concept, we were attempting to formulate a concept that could be applied also in other parts of the world. If you go to India, you get the untouchables who have no way to progress economically, but they look like they're the same people. And you go to other parts of the world, the Hutu and the Tutsi are fighting each other. They look the same. Vietnam. So the issue has to do with an attempt to have a universal meaning. Let us hope that in the future the racial issues will diminish more and more as they are now, and maybe will not be the primary force that is driving social injustice. Maybe something else. Something will always be there, I'm sure. So we attempt to put it in the framework of social injustice instead of racism, which is a form of social injustice, was to make it a more universal concept.
You were being polite. Thanks, sir. Thank you very much.
Dr. Freeman, I think we will entertain one more because it's about 5 minutes to 2 and you have to be in the Senate. Delegate McDonough.
You mentioned cardiovascular disease as a major killer, and I may have missed it. I was trying to listen at the time. Did you attribute that to environmental or lifestyle habits, or did you attribute that to something that's physiological?
I think, from my understanding of cardiovascular disease, there are different elements that seem to drive it. One of the things that we know is that about a third of deaths due to heart disease, cardiovascular heart disease, are related also to tobacco. So you've got a tobacco factor that causes death from cancer as well as cardiovascular disease. The diet issue comes in very strong. It appears that in societies that are closer to vegetarian, there's a lower incidence of cardiovascular disease. So diet having to do with food that could cause harm in the arteries, for example, atherosclerosis. So diet becomes a very important point. There's also a hereditary component in some cardiovascular disease, that you have a family that has a history of death from cardiovascular disease, your personal chances are higher. So the elements that are most pertinent, I think, are tobacco, diet, and whatever hereditary inheritance you may have.
Unlike, for example, sickle cell anemia, which is attributable to a physiological or genetic type of cause, the cardiovascular problem, black men, it's really not due to that. It's due to the traditional reasons that someone would have that problem.
You know, you're asking a very heavy question.
Can I intercede right here? Delegate, Dr. Freeman is on cancer disparity. The cardiovascular, Dr. Christian was stuck at the airport, so he's not here yet. I'm sure he can answer that. But and the sickle cell doctor is Dr. Weisfeldt is going to come up in a few minutes and can entertain your question on sickle cell.
Fine. Okay.
Dr. Freeman, I thank you so very much. I would first, before you go, our chairman is here, Delegate Herson, and our chairman owes, not only is the first chairman who have been able to appoint such a subcommittee as the Minority Health Disparity Subcommittee, which, as we said before, is one of the first in the nation. But he holds many hats. He's also the chair or the president of the National Caucus of State Legislators. So I'm sure we'll be able to talk with you and dialogue with you more on this issue. And I know the Senate is awaiting you. Okay, what did you say?
I'd like to say just one thing. I particularly want to end my remarks by actually congratulating this House of Delegates. I have followed your work, and I know that you're on the cutting edge of this disparities issue. Claudia Bequet has told me about it as well. So there are only a few states in America that have taken this up as you have. And I just wanted to say that what a pleasure and a privilege it is for me to be here to talk to you because of the work that you've done.
Thank you so very much, Dr. Freeman. Do you want to say anything, Mr. Chairman?
No, thank you very much for coming.
And while we're here, quickly, before we switch to Dr. Weisfeldt, Dr. Bequet, could you just stand? Dr. Bequet, she's a School of Medicine Center for Health Disparity. So we do have a center at the University of Maryland. Next to her is Joy Bramble, who's the owner of the Baltimore Times. I'm not going to be able to go through everybody, but I just want to identify. In the back, you have Mr. Howard Henderson, J. Howard Henderson, who is the president of the Greater Baltimore Urban League, and just finished reading your report, sir, on the state of Black America. And health disparity was one of those issues. And I can't see everybody back over there.
The Health Disparities Program.
Okay. And I'm sure there's so, and of course, I would like to also recognize Dr. Malcolm Joseph, who is who heads up the Safety, Care First Blue Cross and Blue Shield Safety and Health Disparity Committee. There are so many people, but I think we need to move on. So at this time, Dr. Myron Weisfeldt. And I just want to tell you quickly, to share with you that about a year ago, I happened to be at Hopkins to talk, I went to Hopkins to meet Dr. Weisfeldt to talk about the Diversity Council that he had created at Hopkins, and was extremely pleased in my discussion that not only did they create the Diversity Council, but they've gone a step further in terms of dealing with the issue of adult sickle cell. And although in the state of Maryland we do a great job with children sickle cell, that are diagnosed with sickle cell anemia, we don't do a good job with those that are adults, because we're still treating many of them in a pediatric kind of a setting rather than in an adult setting. So, and of course, talking with him further in terms of the diversity. If you read, any of you read the Sullivan report that speaks about the disparity in health professionals, and that's another area that he is very well skilled on talking with us. Dr. Weisfeldt.
Madam Chair, Nathan-Pulliam, Chairman Herson, and Vice Chairman Hammond. Thank you very much for your kind introductory remarks and for the opportunity to talk to this group. I represent Johns Hopkins, arguably a leading healthcare institution whose major medical center is embedded in the East Baltimore community, where disparities are an everyday problem and observation that we deal with. Hopkins has made a new and, I believe, serious sequential effort to deal with the problem of healthcare disparities through a number of initiatives, and I'm only going to mention three. One is through our effort to increase diversity of medical students, trainees, faculty, and leaders. In that arena, our medical school now has 13 to 23% underrepresented minorities as students in our medical school. My Osler Medical House Staff, arguably one of the leading house staff programs in the country, is 15% underrepresented minorities, as is true for our fellowship programs. I have 14 division chiefs or leaders within my department, of which 4 are underrepresented minorities, the leaders of cardiology, pulmonary medicine, gastroenterology, and the Welch Center for Clinical Epidemiology and Care, Community Care, are all underrepresented minorities. Those efforts are conscious to recruit and bring to this state as leaders, to train leaders of American medicine that represent a diverse community, believing that problems of healthcare disparities will in part be addressed by increasing the diversity of the physician and the leadership manpower in American medicine, which we believe Johns Hopkins should take responsibility for pursuing. The other two programs I want to mention are disease-related or illness-related. One is sickle cell anemia, and the other is an intensive and enhanced program in substance abuse. In the programs of substance abuse, we have proven that we can, with specialized care, result in abstinence from substance abuse in a very significant percentage of patients. That patients who come in the hospital with substance abuse and have a healthcare problem are at a teachable moment because of the healthcare problem. And that by increasing our capacity to handle and train and educate and bring substance abuse patients into the community using new drugs and agents that are now much easier to use than methadone, a drug called buprenorphine, which is administratable sublingually and by an ordinary prescription. We believe that we can impact on one of the real leaders to disparity that is so prevalent in the East Baltimore community that we work in. So let me then turn to sickle cell anemia, where I have submitted a written statement to you with my comments. The state of Maryland gets high marks for its leadership and its program in the identification and care of children with sickle cell anemia. There is special funding, special programs that identifies these children early and provides specialized care and prospective care once young babies are identified with sickle cell anemia. And of course, that leads to better survival and, in fact, the movement of large groups of these infants now into adulthood where we lack specialized programs. We have estimated that in the state of Maryland there are now 4,000 adults, individuals over age 18, who live with sickle cell anemia, with the crises, the problems that that condition presents. If you're not familiar with it, the most frequent problem is painful episodes that require narcotics for relief of pain, and complications that relate to the vasculature and the fact that the blood cells in this disease sludge and obstruct the flow of blood to the brain, the heart, the kidneys, and other organs. Rapid treatment of crises when these blood cells are sludging and when pain occurs. We know from other centers and other adult programs results in decreased complication rate and decreased use of health care. So the message, the biggest message that I want to leave is that we believe by spending some money on early and prompt and effective treatment of adults with sickle cell anemia when they need care, in fact, will save money for the state of Maryland. So what are we doing? We have a physician who's essentially full-time now in the last 2 years devoted to sickle cell anemia, a paramedic person, nurse practitioner, who is part of the program full-time, and we have a social worker and a counselor who are part-time in the program. The program is entirely funded to date in the last 2 years by the Johns Hopkins Hospital. And we have, as a result of the program, shortened the time from presentation in the emergency department to initiation of treatment with the right medications from 8 hours to 2.5 hours. And a result of the prompt treatment, the specialized treatment, and the approach, we have shortened the length of stay for the average patient who is admitted to the hospital, which is 50% of the patients who come to the emergency room are admitted to the hospital. We have shortened their length of stay by 2 days. And we estimate that with the investment of several $100,000, we are now saving on an annual basis the Medicaid program of the state of Maryland approximately $1.1 million per year. So that's the principle, is you spend some money, you provide quality care results in less health care needs, a better patient, better outcome. And that's what what our program is about. The program, of course, since we treat our patients promptly, has become attractive to patients. So we have gone from 75 patients with sickle cell anemia that we are directly responsible to 175. And we are beginning to receive referrals from the pediatric centers within the community of Baltimore to our program because, to our knowledge, we are currently the only dedicated adult program specifically in the care of sickle cell anemia. So, just in summary, I think my message can be simple, and I think it's brief, is that Johns Hopkins is very serious about the issues of disparity, that we believe that increasing diversity among the workforce, among physicians, among healthcare providers is a critically important element in decreasing disparity. We believe that specialized programs in the problems that do afflict minority populations are part of the answer to decreasing disparity, and certainly in our community, the problems of sickle cell anemia and substance abuse are at that level. And I would actually be happy if the delegate would like to comment further on the cardiovascular initiative, since my own background is in fact as cardiology, and I did at one time serve as the president of the American Heart Association. So I, again, thank you for your attention, and I'd be happy to take questions.
Okay, thank you very much, Dr. Weisfeldt. Delegate Turner.
Okay, we're talking about adult sickle cell. These are adults who just found out that they have sickle cell, or they've been from childhood all the way up to adults?
Most patients with sickle cell anemia, the true SS syndrome, who begin having medical problems almost in infancy or childhood. They're usually very well identified as having this condition. And what we are talking about now is the increasing survival because of better care of those infants into adulthood, and obviously then the need for care in adulthood. There are some unusual individuals. I would say 5% of the adult sickle population who are not discovered to have sickle cell anemia until they are adults, but that's a relatively small group of the patients with sickle cell anemia.
And so you,
Delegate McDonough and then Delegate Benson.
I would offer the same question before, which was reference to cardiovascular disease in black males. Is it attributed to some degree to a genetic or heretical situation, or is it an environmental cause?
Wherever we have looked reasonably carefully, the genetic related issue is prevalent throughout society in variable forms, but not particularly prevalent in minority populations. The environmental factors are critically important that Dr. Freeman mentioned. Smoking and diet and obesity diet are very much part of this picture. But what Dr. Freeman did not mention, which is of critical importance, is health care, is availability of medications and drugs, and the taking of medications and drugs that are indicated for manifest cardiovascular conditions that are identifiable and treatable. And I think you already know what those are. High blood pressure, right at the top of the list, and high lipids or high cholesterol, where we have very effective medications in both circumstances that prevent the consequences of stroke, heart attack, and heart failure that kill, sudden death, that kill people with cardiovascular disease. At Harlem Hospital, there was a pivotal study that was published in the New England Journal of Medicine in about 1975, in which malignant hypertension, which is hypertension totally uncontrolled, that immediately, if not treated, will cause death through edema of the brain, was viewed as perhaps more common in African American and African American males because of a predisposition, genetics. But in fact, the study showed that it was not genetic. It was the lack of treatment of hypertension at a moderate stage that was really the causal factor in hypertension becoming malignant. So even where very severe and unusual manifestations are present, it's much more the issue of the predisposition and the failure of the healthcare system and the disparities that we're talking about to allow the education, the convincing of people about the taking of medications, and of course the cost of medications, which are impediments.
Thank you very much.
Thank you for allowing me to.
Delegate Benson.
Yes, good afternoon. Thank you so much for coming. How far along are we relative to finding out the real reason why sickle cell anemia exists primarily in the African American community? How far along are we with that research? I know at one point in time there was some concern that not enough money was being put into the research of the cause for sickle cell.
Sickle cell anemia is one of the first conditions, first diseases that was proven unequivocally to be due to a genetic alteration, a hereditary genetic change in the chromosomes. And the person who has sickle cell anemia has a sickle gene from both the mother and the father. And it's when you have SS, when both chromosomes or both genes have the alteration, the abnormality, that's when you have sickle cell anemia. The condition is much milder if you have only one of the abnormal genes. It is, I think, a very great disappointment of medicine that despite knowing the exact cause and how, in fact, in a physical chemical sense, that genetic change leads to these abnormal red cells and the sludging, that we have not come up with more effective prevention and treatment for this condition. I can hold a little hope for this, in that we are beginning to be able to do bone marrow transplantation from siblings or parents who have similar genetic background but not identical genetic background, with the use of drugs with some success in terms of tolerance of the recipient for the donor bone marrow that doesn't have sickle cell anemia and doesn't have an exact match. And it is true that in my department at Hopkins we are doing work in this regard with some remarkable success. What's really exciting is that we have a couple of patients in which this has been a success by using the drugs at the time of the transplant, but then not having to maintain the patient on drugs for the rest of their life, as we do with most transplant patients where there's not identical. Most kidney transplant patients you have to maintain on drugs for a long, long time. So that's, I think, a bit of hope in a sea of disappointments with regard to having better treatments for this problem.
Okay, I think our last question will come from Delegate Elliott.
Could you identify the type of person that shows at the hospital, which you indicated 50% are admitted? And also, I'd like to know, what is the average stay that individual may be at the hospital, and what kind of treatment would the individual get?
The patients who come to the emergency department are coming, most of them are coming for pain, or for pain with symptoms of other organs being compromised by the crisis, what we call the crisis they are in. One of the problems is when an African American patient comes into an emergency department with pain, even though they identify themselves as having sickle cell anemia, and they are in need of narcotics and they are in need of injections. And it often takes a long time before there's satisfaction of the healthcare team that this is the right approach and treatment is manifest. So it's fluids plus narcotics in general or other pain relieving medications if possible. And oftentimes those other manifestations are creating other symptoms, nausea, vomiting, and other reasons for the need for in-hospital care. If we can abort an episode, which we can do in 50% of the patients on the average, they will go home, and if not, they will be admitted. Specifically, the average length of stay before we began our program was 6.6 days, and that has been decreased to 4.7 days in our population since 2002. There are, in some, I would add just one more comment about treatment. There are some crises which are difficult enough and show enough signs of being life-threatening that we may use transfusion and exchange transfusion treatment as part of the treatment.
And probably I just wanted to add, I think Dr. Weisfeldt was very careful in answering that question. But many times when African Americans show up in the emergency room with joint pain and the other and need narcotics, many of them are referred to drug treatment programs thinking that they're drug addicts rather than anyone taking a good history to find out that the problem that they do have is sickle cell anemia and that they need immediate care. And so I think with creating the center at Hopkins, that they can be seen within a shorter period of time will save all of us money. Not only, of course, when we talk about disparities, not just African Americans and other minorities that disparity impacts. It impacts on all of us as taxpayers, because if it's going to cost us more and the people will suffer, then we know that as legislators we have to do something about that. And so again, Dr. Weisfeldt, we thank you for the work that you're doing. And I want to say one final comment on sickle cell. I was shocked to find out that because of the work we have done in Maryland and in other places with childhood sickle cell, many of them are living into their 40s and into their 60s. And that is what is now creating a lot of additional problems, because before then they died. And so I was able to meet a very interesting young man that Dr. Weisfeldt brought to my office, who was working on his PhD, who has sickle cell anemia. And I was very impressed and he came to emphasize the importance of moving very quickly to expand this program so people like himself can continue with their lives, because many don't get the opportunity to go through school the way they should because of their education is usually disrupted due to the consistent crisis in their lives from the pain of sickle cell.
I very much appreciate the interest of this body in the problem of healthcare disparities. My contacts with your state government, particularly the Department of Health, have also been very positive, and it's actually a pleasure to work within this environment where this problem, which is such a serious problem, is taken as a problem that needs to be addressed and can be addressed by our society. Thank you for your time and attention.
Thank you very much, Dr. Weisfeldt. I think we will now have Dr. Carlisa Hussain, the Maryland Office of Minority Health and Health Disparities, along with Burdette West, Director of the African American Health Alliance. And while they're coming, I just want to say Dr. Weisfeldt didn't know what he was getting into the day that he met me, because now he's also co-chairing the professional education for the Office of Minority Health.
Thank you very much, Chairperson Shirley, Nathan-Pulliam, and members of the committee. It's a pleasure to present before you today. Let me introduce my colleague from the department, Dr. David Mann. To my right is a physician epidemiologist working with us on this project. You have a copy of my presentation today, and let me say that it comes from both myself and Secretary Tony McCann, the Secretary of our department. And I won't read every part of this, but hit some highlights. The Office of Minority Health and Health Disparities was established within the Office of the Secretary in the department this past spring. I'm now listing some of the accomplishments today. We have launched the website, and the web address is there, and hopefully you will check it and see some of the information. We've held a one-day Health Disparities Conference in June with over 300 attendees who provided recommendations for how Maryland could go about reducing health disparities. We've made 2 presentations this past November at the American Public Health Association Conference in Washington, D.C., along with Shirley Nathan-Pulliam, who assisted with that. And currently, we have 4 statewide committees meeting and working on developing a plan to eliminate health disparities. The middle of the page, I've listed the co-chairs of our committees so that you could see the diversity and the breadth of professionals helping with us. In fact, several of the people are in the room today. For the health professional education, we have Dr. Trudy Hall from the National Medical Association, Dr. Myron Weisfeldt, who just spoke with you, from Hopkins, Ms. Carmen Nieves from La Clínica de la Comunidad. The Access to Quality Health Services Committee, Dr. Claudia Decay, who also was here. She's gone across the street to the Senate. Ms. Alma Roberts, who's President and CEO of the Center for Poverty Solutions. Ms. Bonita Panino from the American Cancer Society, who was here earlier, and she stepped across the street. The Measuring Health Disparities, we have Dr. Tom Levis from the Johns Hopkins Health Disparities Project. Dr. Olivia Carter-Pocris, who's at the University of Maryland and very actively involved in the Latino Health Initiative. The next co-chair position is vacant. There was an Asian person who had to step out, and she's going to help us find another Asian person to be a co-chair there. The 4th and final committee is identifying funding strategies. Dr. Chris Gibbons, also from Hopkins, but from their Urban Health Institute. Mr. Michael Preston, Executive Director of MedPI, who is also here, and Ms. Patricia Horton from the Montgomery County Black Health Initiative. So we have a good, strong group of co-chairs that's helping us put together a plan. And I've asked them to give me a draft by June 30th of 2005, and they're all busily working toward that end. Of course, certainly you know that this will be a beginning process. This planning activity will take multiple years to refine and get a comprehensive document. On the next page, I've listed some of our current activities. We have hired a grants writer, and actually she's here, Ms. Janet Adams. She might wave her hand. She is real, exists. She's going to help us find some federal and foundation funds to support not only the infrastructure of the office, but more importantly, to allow us to be able to issue grants around the state of Maryland to groups who have clear ideas of how they can help reduce disparities. We also will be looking for resources to help us have a very broad and involved health planning process, and also to come up with a mechanism to improve our collection of data and to evaluate the effectiveness of any programs that we launch. Some of the future activities involve holding another statewide Health Disparities Conference in 2005, and as we plan that, we'll certainly keep the legislature, in particular this committee, informed. Now, I'll end on this page with a best practice that actually we have in Maryland, and that is in the Cigarette Restitution Fund program. We actually have successfully reduced health disparities in terms of the death rate of minorities in Maryland from cancer by 55% in compared to the death rate of whites for cancer. That is a big, tremendous success that we have. And we want to, through our health disparities programs that we are now trying to launch across the disease spectrum, to get those kinds of results in other areas. We achieved that from the period of 1992 to date. And of course, the Cigarette Restitution Fund program only started in 2000, but much of that improvement and reduction in disparities occurred during the period of 2000 through today's date. On the next 2 pages, and this is where Dr. Mann will assist me, we wanted to share with you some data about the disparity in death rate for African Americans in Maryland as compared to whites. And before Dr. Mann says a couple of words about this next page, the issue of having data on all the ethnic groups is one that we are working on. We presented the data today with the black death rate because that's where we have large enough numbers and enough complete data to give you accurate rates in terms of excess death rates. We did look, in fact, at the data for other minority groups and found that we did not have sufficient data to run the analysis. But that's our objective, to move to the point that we can present a bar graph such as this for the other ethnic groups. So Dr. Mann, if you would just say a few words about what this page is telling us.
Well, the way we prepared this chart was to have our Vital Statistics Administration generate in each county a mortality rate for the non-Hispanic white population in that county and a mortality rate for the African American population in that county. And we use a method called age adjustment, which allows us to adjust for the fact that the non-Hispanic white population tends to be older, and by virtue of age, if you didn't make this correction, would tend to have higher mortality. So we do an adjustment process, which is a very standard statistical method in looking at these kinds of numbers, that allows us to eliminate the age difference issue across the 2 races. So that gives us a nice standardized comparison. And then we looked at the percentage difference, the percent greater that the African American death rate is compared to the non-Hispanic white death rate, and that's what we've plotted in the horizontal bars on the charts here. And you'll see that we have at the top in the white bars, there's 4 counties where the percentage difference is less than a 10% excess. But then in the next group of counties with the vertical bars, you see an excess that's about 20 to 25% higher. Then just as a reference point, we have a dark bar for Baltimore City. Then in between these are excess rates between 25% and a little bit less than 33% in the speckled bars. Then we have our bar that represents this comparison for the entire state of Maryland combined. That's another dark bar as a reference point. And then some counties where the excess is greater than 33% and less than 50% in the diagonal slash bars, and ultimately one county where the excess rate is 70%, so 70% higher mortality rate in African Americans compared to whites in that particular county. So what we were hoping to illustrate with this was the fact that the health disparities are certainly not unique to any 1 or 2 or few counties within Maryland, and mortality is certainly one of the ultimate endpoints of health to worry about, and clearly we're seeing mortality differences in all the counties, and fairly large ones, 20% or higher, in the vast majority of counties. We also wanted to illustrate that it's not just a problem that might be centered in, say, Baltimore City. It's clear that there are large disparities, and even larger disparities than those found in Baltimore City and many of the other counties in Maryland in terms of this percentage excess death rate.
And I think that's the important point that supports the legislation that was passed, the fact that we have to have a statewide program to address health disparities of minorities in all of these sectors. And on the last page are the actual numbers that reflect the bar graph that we just looked at, in case you wanted to see the numbers. And David will take a moment to explain how you read that page, and then we are ready for any questions.
Right, so in Table 1, which is basically the underlying data that generated the chart, we've listed, actually starting in the far right-hand column, you see the mortality rate in each county, and also there's a line for the entire state. That's the death rate among African Americans, and again, that's age-adjusted, so we solve the age difference issues. We have an age-adjusted death rate for the white non-Hispanic population, and then we looked at the difference between the two and what percentage that difference was of the underlying white non-Hispanic rate, and that's what generated the percent excess that you see in the column that has the box around it. And the numbers in the column with the box are the numbers that are actually plotted in the chart on the previous page.
Can I ask a question? Is there any, doctor, is there any time that would be able to get a chart or something developed that would not only give us the difference in the death rate, but also break down the different causes of the death rates?
Yes, this is like our first data release. Where we're moving to is to get it for by each ethnic group, by the top disparities problems, which we can share with you. Maybe you can mention what those are, and for each county. That is our goal, to get that kind of picture. So each county will be a county local health department, and the physicians and hospitals in those areas will know exactly the nature and where the health disparities are. Just as Dr. Freeman said earlier, you have to really focus your resources, and which we've done a good job of in the Cigarette Restitution Fund program. We need to do that in a similar way in the rest of the state for the other disease categories.
In terms of causes of death, and this is now looking at the state as a whole, because once you take the data that we have and divide it into counties and try to divide that further into individual causes of death, you rapidly run out of enough data to accurately do the age adjustment methodology that we'd like to do. So we're in the process of trying to see if there are some alternative ways to accomplish the age correction by a different method than the usual method that requires larger amounts of data than we would have to do a multi-level breakdown that you're asking for. So these numbers are talking about statewide, not in individual counties, but and we're still kind of working to refine this analysis, but it looks as if perhaps 20% of the excess mortality may be attributable to heart disease. Another 20% may be attributable to cancer deaths. Something in the realm of maybe 10 to 15% might be attributable to HIV disease. About another 10-ish% might be attributable to diabetes, and something slightly less than 10% might be attributable to homicide. So, and that would cover the vast majority of the excess deaths in those 5 categories.
So the answer is yes, we will be working on those refinements.
Well, thank you very much. Is there any questions for Dr. Hussain? Because Dr. Hussain and the doctor, they have to go over to the Senate to speak. Delegate Bob.
Thank you. Just one, when you're working up the future charts, is there any way to work in, when you look at disparity in deaths, and you mentioned a number of diseases, I'm just wondering how smoking per se would have affected these numbers, if there's any differentiation there as a result of people that you've examined who have smoked versus not smoked, and say got cancer or whatever.
The smoking rates for youth and adults by the county area. And we could take a look at that and see what we can show.
Good. Thank you.
That's a good question.
Thank you, Mr.
Any other question? Dr. Hussain, why am I pronounce your name again for me, Doctor?
Hussain.
Not you.
Dr. Mann?
I know.
Dr. Mann, M-A-N-N.
M-A-N.
Sorry.
Dr. Hussain, thank you so very much for sharing with us, and I know that you have to head on to the Senate. Is there any other question before they leave? I'm sure Dr. Hussain will be coming back to us over and over during the year to give us update as to where we are with the Office of Minority Health and Health Disparity. And I, at the same time, would like to recognize Mike Preston in the room from MedChi, because MedChi has been working very closely with the Office of Minority Health and Health Disparity. Thanks. Okay. Now we have Fredette West. She's the director of the African American Health Alliance, but quickly I want to let you know that Fredette, in her other life, was the chief of staff for Congressman Louis Stokes on Capitol Hill, and that's how I met Fredette probably 20-something years ago. And she was instrumental in Ohio when they started their first Office of Minority Health. So she's bringing us a different perspective. We want Fredette to give us a national perspective as where we are with the National Office of Minority Health and how that interfaces with the state.
Good afternoon. Mr. Chairman and members of the committee, the African American Health Alliance is pleased to have the opportunity to appear before the Health and Government Operations Committee today. The African American Health Alliance is committed to the elimination of disparities in health and health care across communities of color. We applaud the committee's creation of the Subcommittee on Minority Health and its assistance in ensuring the enactment of legislation creating Maryland's Office of Minority Health and Health Disparities. These two landmark achievements are vital resources to our state. All Marylanders can be proud of these achievements. Our testimony today focuses on the Office of Minority Health at the federal level and the state level. The Office of Minority Health's effort is central to improving minority health and eliminating health disparities. And as you all are keenly aware, and as you've heard from so many other speakers today, minorities continue to suffer disproportionately from treatable and preventable diseases and illnesses. The state of disproportionate health status continue to increase, while increasing advances in prevention, diagnosis, treatment, and extraordinary developments in behavioral and biomedical research offer incredible opportunity for improving health. It doesn't have to be this way. This compounding and devastating suffering must end, and it's incumbent upon each and every one of us to be involved in that. Therefore, we are encouraged by, excited about, and look forward to working with the National Office and Maryland's Office on Minority Health and Health Disparities as it works to implement the recommendations of the Institute of Medicine's report on equal treatment, confronting racial and ethnic disparities in care. That study found that when access-related factors such as patients' insurance status and income are controlled, again, are controlled, racial and ethnic minorities tend to receive a lower quality of care than non-minorities. Clearly, race does matter. To quote Dr. Allen, the study chair, the committee finished its work convinced that the real challenge lies not in debating whether disparities exist, but in developing and implementing strategies to reduce and eliminate them. And that's why we are so pleased to have this opportunity today and encouraged by the achievements of this particular committee. It is against this backdrop, a challenge and opportunity, that the African American Health Alliance is working to support the efforts of the state and at the national level. The national office is currently up for reauthorization. In fact, health disparities bills during the last Congress included provisions to reauthorize that National Office of Minority Health. However, action was not completed on those bills before that Congress ended. But we are encouraged by efforts that are now underway to redraft and to come up with a comprehensive bipartisan bill to really address health disparities and, for sure, reauthorize the Office of Minority Health.
Could you pull your mic up a little closer with the noise? It's kind of difficult here.
The overriding focus in doing that is that no harm be done. And by that, we mean that the offices are strengthened, not diluted in any way, and that they are provided the necessary resources and staffing to carry out the full scope of their statutory missions. And that's true for the Office of Minority Health at the state level as well. So central to this support is support for healthcare providers and systems of care that are culturally responsive to the communities they serve, including the development of public and private partnerships, and private partnerships that also focuses on communities and involve communities. It's against that backdrop that we asked this committee to call upon the Maryland delegation and the U.S. House of Representatives and in the Congress, that they come together and help support passage and enactment of a comprehensive health disparities bill that for sure reauthorizes and strengthens the Office of Minority Health at the national level. We appreciate the opportunity to appear before you and welcome any questions that you may have.
Thank you very much. Is there any question for Ms. West? Everybody understand everything? There are two bills that were introduced. There was a Frisk bill and the Daschle bill, and we know that there's some change there. Can you tell us how you think the bill may move forward?
Well, efforts are underway. We've met with both Senator Frisk's staff and Senator Kennedy's staff, as well as some of the other Senate and House staff, asking that they work together to craft a bipartisan bill. Within those bills, we support the data components, the Office of Minority Health, but strengthening it in such a way that it has the resources to carry out its mission. So often, the Office of Minority Health pool of money is used for specific earmarks. And those earmarks, while important, they dilute the overall impetus that that office could have. So there must be support from the outside, and that's why we ask for support from this committee to ensure that appropriate funding and staffing levels are provided. Other key provisions include those dealing with accountability as it relates to more involvement of the Office of Civil Rights, the FDA and the work that it does, creating offices of minority health in other agencies of the Department of Health and Human Services. So there's a lot of opportunity within that. Our concern is that as everyone speaks and addresses health disparities now, that we actually get something done that's measurable and accountable, and that quality is going to have to be the leveling factor, and quality for all.
Thank you very much for that. And I just want also to tell the committee that Maryland now joins 10 other states that have a Office of Minority Health and Stature, and there are 33 states in all that have some form of minority health and health disparities. Again, I thank you very much for being here. Yes, our next briefing should be at 3 p.m., but because of the weather outside and she's here, maybe we could just move into that and get it all over. Is that okay with the committee? Yeah? Okay.